This is a due diligence report for transarterial chemoembolization, also known as TACE. We will be reviewing both drug-eluting DEBTACE as well as conventional TACE. The information in this report comes from a recently published data sheet comparing TACE to 𝗧𝗥𝗘𝗦𝗧𝗑 glass microspheres for the treatment of hepatocellular carcinoma, or HCC. First, let's look at the mechanism of action. With DEB-TACE, a chemo agent such as doxorubicin is coupled with the embolic effect of beads. With cTACE, an oil doxorubicin emulsion is injected into the tumor-feeding artery followed by embolization with a gel foam slurry or beads. Next, what are the benefits of each? With DEB-TACE, higher dose of drug to the tumor with lower systemic concentrations than cTACE. Comparable safety profile with lower rates of side effects than cTACE, and an alternative in the setting of high-lung shunt. With cTACE, it is more visible due to the radiopacity of 𝗖𝗡𝗘𝗠𝗢𝗠. It has a lower cost per infusion and it is historically familiar to many. What are the challenges of each? With DEB-TACE, patients must be admitted for 24 to 48 hours for observation of post-embolic syndrome. Permanent embolization of tumor-feeding vessels can make future treatments challenging. There is a time lag involved with the pharmacy to load the beads with the drug. With cTACE, similar to DEB-TACE, patients must be admitted for 24 to 48 hours for observation of post-embolic syndrome. The chemotherapy in 𝗖𝗡𝗘𝗠𝗢𝗠 washes out of the tumor relatively quickly, resulting in less effective tumoricidal effect and more systemic side effects. How many treatments are required? With DEB-TACE, more than one treatment is often required with an average of 1.43 to 2.83 per patient. With cTACE, more than one treatment is often required with an average of 2.5 to 3 per patient. Is there an embolic effect? Yes, there is a high embolic effect with both DEB-TACE and cTACE. Is TACE approved for unresectable HCC? Yes, both DEB-TACE and cTACE are approved for the treatment of unresectable HCC. Does the literature support the use of TACE? A link to the full data sheet is provided below. There are two reference studies, the PREMIER study as well as the TRACE study. The PREMIER study is a prospective, randomized, open-label, single-center study comparing cTACE versus glass 𝗧𝗧𝗧𝗧𝗧 for the treatment of unresectable HCC. The primary endpoint was time to tumor progression, or TTP. The study found that glass 𝗧𝗧𝗧𝗧𝗧 treatment had a significantly longer TTP, greater than 26 mO versus 6.8 mO for cTACE, p equals 0.0012. TRACE is also a prospective, randomized, open-label, single-center superiority study comparing DEB-TACE to glass 𝗧𝗧𝗧𝗧𝗧𝗧. Again, the primary endpoint was time to tumor progression. The TRACE study found that glass 𝗧𝗧𝗧𝗧𝗧 treatment had a significantly longer TTP, 17.1 mO versus 9.5 mO for DEB-TACE, HR 0.36, p equals 0.002. In conclusion, based on the data provided, both DEB-TACE and cTACE are established treatments for unresectable HCC. However, these methods typically require multiple treatment sessions, and their high embolic effect can restrict subsequent therapeutic interventions. The presented clinical trial data. The PREMIER and TRACE trials suggest that 𝗧𝗏 may offer an improved time to tumor progression and potentially a more favorable profile for future treatment options compared to both DEB-TACE and cTACE. Please let us know if you have any questions. Thank you for watching.